Hi folks, welcome to today's Young India Intensivist Critical Care webinar. So today is our international faculty webinar and we have a very distinguished faculty all the way from Belgium with us, Dr. Hannah Schaubroeck. She's got wonderful qualifications in the sense that she's not only an intensivist but a cardiologist also. I think that must be very, very few in the world to have such qualifications. And we really thank her for sparing her time and taking this webinar. And just to go through her introduction, she's, like I told you, a cardiologist and an intensivist. She works at Ghent University Hospital, Belgium. She's principal investigator, MCS Registry, Belgium. She has been the president of the Young ACVC board member and president, and now she's a board member for 2024. That is European Society of Cardiology. She's the past president and current board member of the Belgian Interdisciplinary Working Group of Acute Cardiology, BioAC, and she's the instructor ECMO course at the Ghent University Hospital. So I think it'll be wonderful listening to her. You know, she's being a cardiologist and an intensivist. I think there's no one better than her to tell us about cardiogenic shock. So we'll take all your questions in the end. And guys, if there are any questions in between, please try to participate and answer them. It'll be kind of interactive. Thank you, everybody, and I hand it over to you, ma'am, for the webinar.
Thank you. I'm very honored to be invited by the Young Intensivist Club of India and to discuss cardiogenic shock, one of my favorite pathologies. So thank you for the invitation. So I will first discuss definitions and concepts and then focus on management of cardiogenic shock with a small side path to drugs and devices and their evidence in the management of cardiogenic shock. I will also try to discuss a practical approach using a case. So the first question is, what is cardiogenic shock? It should be a clinical diagnosis. So it's a cardiac disorder that results in both clinical and biochemical evidence of sustained hypoperfusion. So when, for example, an acute myocardial infarction occurs, a downward spiral will start. On one hand, there will be pump failure, leading to hypotension and less peripheral and coronary hyperperfusion. On the other hand, left ventricular anti-systolic pressure will rise, inducing pulmonary edema and further hypoxia, and these factors will aggravate ischemia. As a compensatory mechanism, fluid retention will take place and vasoconstriction, and this will even increase further the cardiac dysfunction. On top of this, a systemic inflammatory response reaction will take place, inducing vasoplegia, microcirculatory failure, and contributing to the downward spiral of cardiogenic shock, progressive organ dysfunction, and eventually death. So in acute heart failure, two main clinical features are very important: perfusion and congestion. So the main clinical feature in the cardiogenic shock patient is hypoperfusion, and this can be accompanied by congestion. However, a minority of the cardiogenic shock patients present in a dry and a cold status. So a very important question to answer is, are there any signs of hypoperfusion? Agitation, somnolence, tachycardia, a narrow pulse pressure, a mottled or cold skin, oliguria, or biochemical signs of hypoperfusion, such as an elevated lactate, an acute kidney injury, an acute liver injury, and lactate acidosis in general. So these signs we should look for when thinking about cardiogenic shock. We should not confuse flow with pressures, since some cardiogenic shock patients are still normotensive with hypoperfused, while others have a low blood pressure but are not yet in shock. So patients with a normotensive cardiogenic shock have a worse prognosis than patients presenting with hypotension without hypoperfusion. This is very important to remember. There are two main aspects that determine cardiogenic shock. On one hand, severity of the shock, and on the other hand, phenotype of cardiogenic shock. And these are both dependent on several factors. For example, the need for vasopressors, the need for temporary mechanical support, but also some hemodynamic profiles might play a role in defining cardiogenic shock. So first of all, we will discuss the severity of cardiogenic shock. Looking at cardiogenic shock severity, we should think about the scai classification. This has been introduced lately, and it goes from A to E. A is a patient at risk to develop cardiogenic shock, to E a patient who is dying and has a complete metabolic and cardiac failure, and we call this sometimes the cardiometabolic or the hemometabolic shock, which is the result of a cardiogenic shock combined with a systemic inflammatory response reaction. So several factors can also modify prognosis apart from this classification, such as the presence of a cardiac arrest, the presence of comorbidities or frailty. This can all influence the severity of the cardiogenic shock. So I would like to recommend the following consensus paper, and in this figure you can see the several shock stages, and a higher shock stage is accompanied by changes at several levels. In the beginning of the shock, blood pressure can be preserved due to compensatory peripheral vasoconstriction, but this diminishes while shock advances and vasoplagia kicks in. Microcirculatory failures becomes more apparent when the shock becomes more severe, and eventually multiple organ dysfunction and death will occur. So this is a very nice schedule to illustrate this. When we are looking at phenotype, the first important distinction is the distinction between left ventricular, right ventricular, and biventricular failure. A first assessment can be performed by echocardiography, but secondly, a pulmonary artery catheter assessment might be of added value to determine which part of the heart is failing and to guide further management. The phenotype is also important for the prognosis. So patients with isolated left ventricular failure do better than patients with biventricular failure or right ventricular failure. The congestion pattern also matters, with biventricular congestion being a very bad marker of prognosis. Phenotype is also linked to the etiology of cardiogenic shock. So in Europe, for instance, acute myocardial infarction is still one of the most important causes of cardiogenic shock. In the US, this has shifted to more non-ischemic causes. And this etiology is important to determine where to go with our patient. This was also nicely shown by the Shock Academic Research Consortium, the SHARC. This is a multi-stakeholder group, including representatives from the FDA, from other governmental agencies, industry, doctors, and they form a group to develop pragmatic consensus definitions to perform research in cardiogenic shock. This definition can also be applied in clinical practice, and they divide cardiogenic shock into 4 main categories. The first one is the AMICS, or the acute myocardial infarction related cardiogenic shock caused by STEMI or non-STEMI, and which might respond differently to certain therapies than, for example, the second group, the heart failure related cardiogenic shock, which can occur in the setting of acute heart failure or in the setting of acute on chronic heart failure. A third group consists of cardiogenic shock due to other causes such as valvular disease or arrhythmias. And the last group is the post-cardiotomy cardiogenic shock, which occurs in patients post-cardiac surgery. These groups are really important to start from when you are managing a patient in cardiogenic shock. In the future, probably there will some other ways of phenotyping patients, so with artificial intelligence or by biomarkers. This will lead us too far for now, but this might open doors to more targeted treatment in the future. So let's take a look at the management of cardiogenic shock. Our goals are quite simple. We want to identify and stabilize our patients early. We need an early escalation if necessary, and we need to avoid evolution to multiple organ dysfunction. And of course, our ultimate goal is to increase survival with an intact neurological status and, if possible, also cardiac recovery. In order to reach these goals, we can follow the steps of the chain of survival in cardiogenic shock, which is similar to the chain of survival in resuscitation. The first step is early recognition, then early stabilization of the airway, breathing, and circulation. We need to treat the cause if possible, and an early step up and optimal ICCU care are also equally important. In order to manage these patients, we need a strong multidisciplinary team consisting of a cardiologist, intensivist, anesthesiologist, cardiac surgeon, intensive care nurse, perfusionist. All these people should work together to manage these patients. We also need a good protocol tailored to the center you are working in, and we should be available, the shock team should be available 24/7. Why are we talking about shock teams? There are some data that shock teams improve prognosis in patients with cardiogenic shock. This concept has, for example, been demonstrated in this retrospective analysis in North America and Canada. And centers with a shock team and a shock protocol had a lower CICU mortality than centers without. In an ideal world, we probably should organize cardiogenic shock like we organize trauma, with several levels of care and with a hub and spokes model where patients are referred to the hub when there is a cardiogenic shock, and in which case there is a need for long-term solutions such as an LVAD or a heart transplant. So this might be the future for a lot of patients with cardiogenic shock. So this idea of a shock team and a protocolized flow is also nicely depicted by Tirani in this article. So the first step is identification and classification of the shock state and stabilization, followed by revascularization in case of an acute myocardial infarction-related cardiogenic shock, and also followed by a comprehensive hemodynamic assessment to aid the phenotyping of our patient, which part of the heart is failing, and to guide further escalation to mechanical circulatory support when the patient is deteriorating, followed by optimal critical care. And for this, we need a multidisciplinary team, and the diagnosis should be made first clinically, and secondly, it can be confirmed with a pulmonary artery catheter. So to make it a little bit more practical, I would like to present to you a case of a 49-year-old male patient who collapsed in the shopping mall and had ROSC after 1 cycle of CPR. He experienced angina at exertion the weeks before the collapse. He was lucky because there was a nurse in the neighborhood with a defibrillator in the shopping mall, so it went all very fluently. He was known with a bipolar disorder with a reflux, gastroenteric reflux disease, and a mild chronic kidney disease. He was a smoker, had a lot of stress, and he had also a positive familial history with a father who had a cabbage at the age of 52. His only medication was lithium for his bipolar disorder. So at the emergency department, he had a preserved systolic blood pressure, but it was a bit borderline, a narrow pulse pressure, a slightly elevated heart rate, no fever, no problems with saturation. He had cold extremities. He was adequate, well-oriented, but a bit somnolent, and for the rest, there were no abnormal findings. So my first question to you is this patient in cardiogenic shock? I leave you a minute to think about it, but I would like to help you a little bit with this. So the blood pressure is indeed preserved, but there are cold extremities, there is a narrow pulse pressure, there is tachycardia, and there is a high suspicion of a cardiac disorder. He had angina and had a cardiac collapse. So I would say consider shock at the beginning, because it all starts with the consideration and thinking about cardiogenic shock. For example, this lady is an American lady that I once met, and she was not diagnosed in time, had big consequences due to this delay. And she is really an advocate now of detecting shock in an early stage. So I would recommend to you to read her story. So we are considering shock in this patient, and there are a lot of things that should take place simultaneously. For example, the initial approach should go hand in hand with initial management in an ideal world within 2 hours after admission to the emergency department. So what do we need to do first? We need to confirm our clinical diagnosis with an ECG, and chest X-ray, echo, and labs. Here you can see the first results. So the patient shows signs of ischemia on his ECG. He has an elevated lactate with a metabolic acidosis, and he has a very bad, very poor left ventricular function at the focused echocardiography that took place at the emergency department. So he's for sure in shock if you see these values. So is it important to do an echo at initial diagnosis? Is another question for you. I will help a little bit. So I think it's mandatory because you can identify the type of shock, obstructive, distributive, cardiogenic, you can have an idea of filling pressures left side, right side, and this can guide your detection of etiology and phenotype and can guide your initial management too. So looking at all the values, we can decide that our patient is in a cold and dry status in the SCai classification stage C. And we can also classify him in, we think he has an acute myocardial infarction, so we can classify him in this group, and we need to consider looking for the cause in the first place. So the next step is to stabilize the patient, fluids, vasoactive drugs, oxygen, and then also activate the shock team. So early ABC in these patients, for our particular patient was quite stable at the beginning. So he had a nasal cannula of 2 liters oxygen, and he received a fluid bolus, and he received heparin and aspirin for the acute coronary syndrome. But then the blood pressure did not really respond well to the fluid bolus. So what should we do next? Should we give more fluids? Should we give noradrenaline, dobutamine? Should we go for MCS? What do you think? So first, for stabilization, we need to give oxygen. But if oxygen is not enough, we can go for non-invasive ventilation. This is also good in left ventricular failure because it can reduce LV afterload. And the threshold for invasive ventilation and intubation should be low in order to restore the balance between oxygen delivery and demand. This was also shown in a post-hoc analysis of the culprit shock trial, which demonstrated a lower 1-year mortality in patients that were ventilated upon hospital admission compared to delayed intubation. Another group has seen that there was an association between 30-day mortality and each 1 hour delay in intubation in patients with refractory cardiogenic shock. However, we all know that these patients are very delicate to do an emergency intubation. So it's very important to stabilize circulation first before the intubation in order to avoid hemodynamic collapse of this patient. So we already discussed the need for evaluation with echocardiography, but also invasive monitoring with an arterial and central line are necessary to guide management. Prudent fluid administration can be done, but if not responsive, a vasopressor, noradrenaline should be started. And if needed, dobutamine can be associated as first-line inotrope. This is according to the ESC guidelines. As vasopressor, they recommend norepinephrine or noradrenaline. And as an inotropic agent, they say you may consider in patients with a low systolic blood pressure and evidence of hypoperfusion to give an inotropic agent, but not when the patient does not have any of these. Then they would recommend against. So how are these guidelines made? There is some evidence, but it's not a lot in using vasoactive drugs. First of all, we need to consider that adequate perfusion pressure is actually the way to preserve organ perfusion. And the mean perfusion pressure is actually the MAP, the mean arterial pressure minus the central venous pressure. So we can influence these factors, influencing MAP and influencing CVP with all our vasoactive drugs. And this we should think about when choosing for a certain product. So we have a lot of options here. We can have pure vasopressors like vasopressin, which can, for example, be useful in patients with right ventricular failure who do not need to have a lot of inotropic support at the first place, but they need perfusion pressure by increasing the MAP with vasopressin. This can be useful. Another group which could benefit from vasopressin are the mixed shocks. Patients that have a SIRS reaction, have a lot of vasoplegia, they could be helped with vasopressin. Inoconstrictors like noradrenaline, adrenaline, dopamine can be used. They all exert a certain effect on the alpha-1 and the beta-1 receptors. Noradrenaline is still the first choice, and I will come back to that in a second. Inodilators are also sometimes useful. We have dobutamine, but we also have milrinone, enoximone, and levosimendan. And these can also help to reduce congestion, for example, because they give vasodilation. So I will highlight the most important trials in vasoactive drugs. The SOAP2 trial was the trial who made noradrenaline being the best vasopressor or the first choice in cardiogenic shock. So in the SOAP2 trial, all types of shock were studied, and they compared dopamine versus noradrenaline in terms of 28 days mortality. In the subgroup of cardiogenic shock, noradrenaline was associated with a better survival. So that's why. Adrenaline has also been extensively studied, and mostly in a retrospective way. And in 2018, there was a meta-analysis showing that the use of epinephrine was associated with a threefold increase of risk of death in these patients. We need to be cautious with these results because they were retrospective, so it's not so easy to be sure that adrenaline was really the cause of the increased mortality. There was an attempt to do a randomized controlled trial comparing epinephrine and norepinephrine in cardiogenic shock. They had to end the trial prematurely because of the higher incidence of refractory shock, the primary endpoint, in the patients who received adrenaline. There was also a trend towards more death in these patients. So it was stopped prematurely, and so the conclusion was to avoid adrenaline as much as possible. Then there was a DOREMI trial a few years later, which compared milrinone versus dobutamine in cardiogenic shock, which showed no difference in the primary outcome, which was a composite endpoint of in-hospital death from any cause, stroke or cardiovascular or renal events. So there was no difference in this composite endpoint. They found a bit more arrhythmias in the dobutamine group, but actually there was no big difference in general. So in general, the evidence to choose a certain inotrope remains low. And there was a meta-analysis from Cochrane who said that no convincing data were there to support any specific inotropic support. An interesting study was done comparing similar hemodynamic decongestion with vasodilators versus inotropes, and they saw that actually milrinone and levosimendan had a similar way of decongesting the patients compared to, for example, the vasodilators, the pure vasodilators. So for patients with left and right-sided congestion in acute heart failure and cardiogenic shock, these drugs might also be of benefit. So if we go back to our patients with acute myocardial infarction-related cardiogenic shock, who was deteriorating, who already received some noradrenaline, he was transferred to the cath lab because we need to treat the cause when there is a cause that is reversible. So this was shown in 1999. Early revascularization in AMICS improves outcomes. This was the SHOCK trial, the landmark trial in this kind of patients. And in 2017, the culprit shock trial was published, which showed that in the initial phase, only the culprit lesion should be treated and multivessel PCI should be deferred to a later stage. So our patient received a coronary angiogram. This showed an occlusion of LAD, RCA, a stenosis of the circumflex and the intermediate branch, and also a severely impaired left ventricular function. During this procedure, our patient is deteriorating further. He got intubated, mechanically ventilated. He has oliguria, he has noradrenaline, dobutamine. So the patient is clearly moving towards scai stage D, cardiogenic shock. So what are the treatment options now? First of all, we did a complete hemodynamic assessment of this patient with a PA catheter, revealing a predominantly left ventricular failure based on the Swan-Ganz parameters. So do we need a PA catheter in terms of outcome? This has been abandoned after the ESCAPE trial, but is now a bit reviving. There was a retrospective analysis showing better survival in patients managed with a PA catheter when complete assessment with the PA catheter was done. But at present, there is a randomized controlled trial running to explore this question if PA catheters really can improve outcome in patients with cardiogenic shock. So going back to our patients, what would be the next step? So you could give more fluids, more inotropes. You can go for mechanical support, or you could go for a shock team discussion first. I think we should go for a shock team discussion first, because we need to know which kind of step up we should do in this patient. And this depends on a lot of factors. When we are looking at the ESC guidelines, there is a more strong recommendation for mechanical support than for the vasopressors and inotropes. But this was also before all the new studies came out. So this is quite amazing that this was giving a 2A recommendation, but they stated that short-term mechanical support should be considered in patients with cardiogenic shock. And indeed, there are some considerations when thinking about devices. First of all, we need an optimal timing of the implantation of a device. If it's too early, it probably will not help. If it's too late, it's futile. So this is very important. Then we need to select the optimal support for our patient. And we should try to prevent complications and think about this too. So how can we choose between all these kinds of support? First of all, I would like to recommend this paper, an expert consensus paper on the percutaneous ventricular assist devices. And it is nicely shown there what kind of devices can help for which kind of failure of the heart. So we have the device for the left side, IWP, Impella, Tandem Heart, VA ECMO, and we have the device for the right side, Impella, Tandem, RVAT, Protect Duo, and VA ECMO. So these devices are all there to choose between. So to choose the right type of support, first of all, the severity of the cardiogenic shock is important. Is there a high lactate? Is the patient metabolically completely deranged? Is there a lot of vasopressors? How are the hemodynamic parameters? We need to know the phenotype. Is the right side failing? Is the left side failing, or are both failing? Is there a problem with oxygenation, and should we also support the respiratory side of the patient? And a very important point is, are there any contraindications against mechanical support in general? Is the patient too old, too frail? Is it futile? Is there anoxic brain injury? Are there important comorbidities? And was the patient resuscitated for a very long time? Then we might to decide not to use mechanical support in these patients. The last very important point in choosing the right mechanical support is also that there should be a long-term plan. Mechanical support should be a bridge towards recovery of the patient, or towards an LVAD or a heart transplant. And in some cases, we need to buy time and use the device as a bridge to decision. But this shock team discussion should lead to a long-term plan. Going back to our patient, he's young. He has some comorbidities, but not a firm contraindication for mechanical support. And then we saw that he had mainly left-sided ventricular failure. So we should think about these left-sided devices. And so we had the choice between an intra-aortic balloon pump, a percutaneous LVAD, or an Impella, and a VA ECMO. I will briefly discuss all of those in a minute. So an intra-aortic balloon pump delivers mainly diastolic augmentation. Advantages of this is that it is a small device, easily insertable at the bedside. It gives some kind of afterload reduction. There is no anticoagulation needed, and it's a relatively low cost. What is less interesting about the balloon pump, it's a low level of this support. There is no pulmonary support. Patients are immobilized because it's mainly in the groin. There can be limb or kidney ischemia. There is a bleeding risk. And if the heart rhythm is too fast, it will not work properly. When we are looking at the evidence, there was a meta-analysis in 2015 showing that IWP had no added value compared to the placebo. So this was mainly based on the IWP Shock 2 trial by Thiele and his colleagues in 2012. And since then, we saw a vast reduction of IWP use in these patients. This was only studied in the AMI cardiogenic shock population and not in other types of cardiogenic shock. We also saw then a rise of Impella CP and a rise of ECMO simultaneously with the decrease in use of EABP. But EABP might be useful in some kind of shock, for example, in the heart failure-related cardiogenic shock. This was nicely studied by Malik. So they saw a change in cardiac output when using an intra-aortic balloon pump in patients with heart failure-related cardiogenic shock, and they did not find a lot of augmentation or improvement of the cardiac output in patients with acute myocardial infarction-related cardiogenic shock. So it seems that there is a difference in the pathology, pathophysiology, and we think this is mainly explained by the sensitivity of the heart, the failing heart, to afterload. So if your patient has already an acute and chronic heart failure, there will be a response to a mild decrease in afterload, and the balloon pump can decrease the afterload for the heart, which can be beneficial. So this will be studied in this specific population in the ALT-SHOCK phase 2 clinical trial. They will study the benefits or the lack of benefits of the balloon pump in these patients. A second device that we can use in predominant LV failure is the percutaneous left ventricular assist device, or Impella. These are microaxial pumps pumping the blood out of the left ventricle into the aorta. There are two main types of these for LV failure. Impella CP, which provides 3.7 liters per minute of support, which is normally placed through the groin and the femoral artery. Or there is a surgical one, which can give full support of 5.5 liters per minute, and this should be done by a graft on the subclavian artery. So the following hemodynamic effects occur when implanting an Impella. The flow will increase, the MAP will increase, and on the other hand, the LV end diastolic pressure and the end diastolic volume will decrease. This will reduce wall tension and help to correct the balance between oxygen demand and oxygen supply in the heart. And it will increase cardiac output. So what are the main advantages of Impella? It's that it's not too easy, not too difficult to insert if you have a little bit of experience, if you have trained for it. It can provide ventricular unloading, and it might reduce infarct size and lead to more cardiac recovery, but this is yet to be proven. This is studied in animal models, but it should be confirmed in humans too. When using the 5.5, there is mid to long-term support that can be provided, and then patients can be mobilized, which is an advantage in ICU, that you can rehabilitate these patients while waiting for recovery or waiting for heart transplant of LVAD. On the other hand, it can be malpositioned, and then if it's malpositioned, it can give insufficient support, and it can cause hemolysis, which is one of the complications of Impella. There is no possibility to support the right ventricle or to provide pulmonary support, and when inserted femorally, there is no way you can mobilize your patient, because this is very sensitive to rotations, and there is also a substantial risk of bleeding and limb ischemia in these patients. And I didn't mention the cost yet, but it's also a very costly device. When we are looking before 2024, there was not a lot of supporting evidence for the device. This was mainly based on retrospective and matched cohort analyses, and it mainly showed that there were more complications with Impella, more ischemia, more bleeding, and no benefits in terms of mortality. However, in April, the Danger Shock trial was published in the New England, showing that patients who received Impella, patients with a cardiogenic shock based on a ST elevation myocardial infarction, so this is a very specific group of cardiogenic shock patients, that these patients benefit from Impella in addition to the standard of care in terms of death from any cause at 180 days. They also looked at safety, and they saw there were more complications, limb ischemia, bleeding, and so on, in the group with a microaxial flow pump or an Impella. But this did not lead to more mortality in the end. Mortality at 180 days was 58% in the conventional group and 45% in the group which received the microaxial flow pump. The following device we can use is the ECMO, so it's a parallel heart-lung circuit which can provide gas exchange and also hemodynamic support. Normally, the blood is taken from the veins and given back into the aorta, so the pump can pump the blood into the oxygenator where gas exchange can take place. There are several configurations and several cannulation sites possible. In most cases of AMICs, these are cannulated peripherally in the groin. What is the consequence of an ECMO? This can increase the ventricular stroke work, and in comparison with Impella, this is a big difference because the blood is given back upstream. So afterload can be increased with subsequent stages of blood clot formation, and this can also increase the end diastolic pressures leading to pulmonary edema. On the other hand, it's venous drainage, and the RV will be drained well by the system and might benefit from this type of support. Also, ECMO has been studied in randomized controlled trials in the AMICs population, so the patients with cardiogenic shock due to an acute myocardial infarction. This is the only group which is well studied for now in randomized controlled trials. And I will show you these in a minute. So what is the advantage of ECMO? Full flow support up to 6 to 8 liters. If you have metabolic derangement, you can correct them with your ECMO. There is one single device for biventricular failure. There is the possibility to help the lungs too. It can be inserted quite rapidly when you have experience at the bedside, and the cost is relatively low compared to, for example, Impella. So the risks I already talked about, this insufficient LV decompression, but it can also induce bleeding. The canulas are large, the patient is mostly immobilized, and you need an experienced center with a perfusionist who can manage these devices. The weaning can be challenging because the heart might recover, but the lungs might not have recovered yet. So this may induce a risk of differential hypoxia or the Harlequin syndrome. So there are a lot of challenges in managing these patients. So the ECLS shock trial was the trial that was published in 2023, comparing ECMO in selective acute myocardial infarction cardiogenic shock patients versus medical therapy, only with the possibility to escalate to mechanical support if the therapy was insufficient. These were patients that had a revascularization in general. It is one of the biggest criticisms on the study was the inclusion of more than 70% of resuscitated patients, because these patients might present with a different type of shock than patients that were not resuscitated before. And there was also a lack of unloading strategies when using ECMO. So ECMO has the disadvantage to have problems with unloading. So the afterload is increased, and sometimes it is necessary to put in another device to prevent this problem. A meta-analysis was also done based on the 4 trials that studied ECMO in cardiogenic shock, and also in that meta-analysis, the 30-day mortality was 47%, and there was no difference between the placebo group and the standard of care group versus ECMO. This does not necessarily mean that we should abandon the strategy, but the patient selection is the key to success. So how will we choose the right support for our patients? First, is there any contraindication for mechanical support? Is there an ongoing cardiac arrest? And in the eCPR setting, ECMO is the only way to support the patient. Is there severe respiratory failure? Then an ECMO could also be of additional use. And then your phenotype is also important. If you have biventricular failure, ECMO can be more appropriate than, for example, Impella. So this flowchart is very illustrative. Our patient had severe respiratory failure, had no severe respiratory failure, had no ongoing cardiac arrest, and he had a predominantly LV failure. So he was put on an LV percutaneous left ventricular assist device. as you can see here on the X-ray and also on the echo. So after stabilization, a cabbage was performed because there was 3-vessel disease. Patient was on Impella and was treated in an optimal way on ICCU. And after introduction of chronic heart failure medication, the patient could be discarded to the cardiac ward and then went home with a stable situation. So to summarize, we have a lot of factors to take into account when managing a cardiogenic shock patient. We should integrate the cardiogenic shock severity and the phenotype. We should discuss the patient in a multidisciplinary shock team, and we should use a dedicated shock protocol. And then we can reach a tailored management of these patients, bearing in mind the chain of survival, which I illustrated with the case. This was also nicely summarized in this supplement of the European Heart Journal about cardiogenic shock. First, we need diagnosis, early detection of shock severity, phenotyping, and the possibility of mechanical circulatory support. We should think about prognosis, non-modifiable factors, cardiac arrest and anoxic brain injury, the shock severity again, and the presence of organ failure or complications. We should go for early intervention if it's an acute myocardial infarction related cardiogenic shock. We need to limit the door to balloon time, and probably we need also to limit the time to mechanical support, which was now shown in the danger shock trial. We need to consider escalation or combination of devices soon enough. And when one of the devices can be weaned, we should do this according to a defined weaning protocol. We should have a shock team, a multidisciplinary team to discuss these patients. In an ideal world, there is a hub and spoke model with a network, and patients should be referred to the center which can offer LVAD and heart transplant in the end. And then we need a standardized protocol. In the future, I hope we will advance further with the biomarkers, with artificial intelligence, and we might go to personalized targeted treatment in the end, which might improve prognosis in these patients. So I would like to thank you for your attention. I would also like to recommend some ACVC activities if you're really into ICCU care. Then I think the ACVC school is also a very interesting event to attend. Thank you very much for being here.
Thanks, Dr. Schaubroeck. Lovely presentation, lovely lecture, lovely listening to that. Can you please stop the share screen?
Yes.
Yeah. So thank you so much. I request the audience to type in the questions if they have any. Meanwhile, Dr. Schaubroeck, I can probably put up a few questions which would be of interest to everybody. So going through your slides, you had mentioned about vasopressin's use. So literature often mentions that you should not be using this in cardiac patients. Is that okay? Or what is your comment on that?
I think it's not well studied, but I do think that we should tailor our choice of vasopressor to the underlying etiology and phenotype. So if you have, for example, this mixed shock or you have an RV shock, I think vasopressin has its place to support the patient, probably not in monotherapy, but it will be an added value to use it in these patients.
So I think if the coronaries are okay, then it's safe to use it, right? And I think you say in RV shock because vasopressin does not cause pulmonary vasoconstriction, so it's probably a good choice, right?
Yes, indeed. Yeah, that's
okay,
right.
Great. Okay, then moving on to the other slides, about the choice of norepinephrine and dobutamine as ionovasopressors in cardiogenic shock in the early stages. So how do you choose, whether we should go with dobutamine first or norepinephrine first? Can you elaborate a little on that?
Yes. So so as illustrated by the SOAP2 trial, noradrenaline seems safer than dopamine. So we do not use dopamine anymore in our country. When looking at dobutamine, sometimes we need a little bit more than only vasopressor support. So the first line is vasopressor support with a little bit of ionoconstriction. But if this is not sufficient, we probably need an inotrope. And then this is difficult. So the guidelines say that we should choose dobutamine then as a first line after noradrenaline, so the first choice inotrope, but there is not a lot of evidence to support this. So in general practice, I would look at the pathology which is in front of me. So for example, if a patient has a lot of congestion, has a lot of RV problems as well, when presenting to the emergency department, I might choose milrinone over dobutamine, but this is not based on guidelines or on evidence.
Thank you. Then moving on to systemic inflammatory response syndrome, you've shown a slide. So how does systemic inflammatory response syndrome change the clinical picture and also our management of cardiogenic shock?
So most of the time, this is not present at the beginning, at the early presentation of a cardiogenic shock. But sometimes when cardiogenic shock is evolving, patients will develop this systemic inflammatory response syndrome. The people that are most prone to this are people who experienced the cardiac arrest and were resuscitated for a long time. These patients have also a post-cardiac arrest shock, which is most of the time not only cardiogenic, but also a strong vasoplegic reaction. So it really depends a bit on what is going on before presentation. And patients who are presenting in a late stage of shock with already multiple organ dysfunction present are most of the time patients that also experience some degree of systemic inflammatory response syndrome. So we should be aware. So most of the time your patient will be very constricted, mottled, but if your patient is getting has signs of vasodilation, or then you should be aware of this. And a very good way to measure it is to use the PA catheter, where you can follow your systemic vascular resistance and see what happened with that.
Thank you. So the other question is about levosimendan. What is its role? Where do we use it? Trials have not really shown it's helpful compared to dobutamine or milrinone. So would you recommend using it, and in what situations?
Yes, so this is also a very delicate point, and it's not a lot of evidence to support it. The only evidence in levosimendan was after cardiac surgery, which has shown to improve renal function in the post-cardiac surgery population with patients with LV dysfunction. So we use it when, for example, we want to wean patients from mechanical support, but this is not supported by any evidence. But we see that we can wean patients from mechanical support with levosimendan sometimes. Other people think we should not wean patients from mechanical support with levosimendan, but just use chronic heart failure therapy and then wean the mechanical circulatory support device very slowly. But all these strategies are really not studied. So I think in patients that really need, also the patients that really have a diastolic heart failure that need relaxation, these patients also can benefit from levosimendan. Yes. So I'm not so scared to use it because it gives a profound vasodilation. When your patient is really in a clear cardiogenic shock state, I'm not afraid to use it.
Thank you. So the other thing is about this thing. Just a couple of your use of IABP. IABP, like you showed the trials and all, it's not helpful. Everybody knows that people use it, and especially in our country, where there's resource limitation and so many parts of the world, is cheap, right? So is it okay? You have a lot of experience. So should we go ahead with the IABP? Does it actually work, and where should we use it? Yeah.
Also a delicate question. So in the acute myocardial infarction related cardiogenic shock, I think we should be very cautious to use it and not to use, for example, Impella if we have this. The best indications for me are the patients that have this heart failure related cardiogenic shock. So they have chronic heart failure and they decompensate and they are not doing well, but they can improve a lot by giving them an IABP. The patients with mitral regurgitation that have a problem with afterload, these can benefit from an IABP significantly. And sometimes we also use it as bridge to surgery, for example, with a patient with a left main stenosis who needs a CABG. you can put in an IABP in order to wait for the surgery to improve perfusion a little bit. But still, this is not following the current guidelines around IABP. Personally, we still use IABP a lot also in acute myocardial infarction-related cardiogenic shock. In the mild shocks, we can see this can give a little difference in outcome for these patients, but it's all about patient selection. I think if your patient is too far gone in his shock, it will probably not work at all.
Thank you. So some of your slides showed CPO, cardiac power output, though you didn't talk about it. Is it helpful, because there is literature to say that at such and such cardiac power output, you should use a mechanical circulatory device, starting with IBP. If it deteriorates, then you put in a impeller and like that. So is it really done or what?
But I think the evidence around this is quite okay. So I think it's quite a reliable parameter to titrate support. But I don't think you need it always. Sometimes the clinical picture can also give a lot of information, but it can, if you really doubt about is it necessary to escalate or what is the main problem here, then I think it could be a very useful tool to guide your management.
Thank you. Just now finishing off, Dr. Schaubroeck, couple of last questions. You have this concept of patient being on the ventilator, and let's say he has a cold and he has pulmonary edema with hypotension, he's on the ventilator. So the transmural pressure decreases for the LV, right? The ventilation is supposed to pump out the blood from the LV because it compresses the LV during systole. But at the same time, my question is, it also compresses the aorta, which is intrathoracic. So it should not be helping ideally, right? It's compressing the LV as well as the aorta, so the gradient is not decreasing. So how does that work?
That's a good question. I cannot answer this straight away. So in practice, I think we see that patients that are ventilated are doing a bit better, and this is probably multifactorial, not only due to the changes in pressure, but also due to the reduced demands and the better match between demand and supply. So I'm not sure that one thing is really causing the benefits of the ventilation, yes or no.
Thank you so much. Just last question, Dr. Schaubroeck. Thank you so much. So this is about the action of norepinephrine, epinephrine, dopamine, dobutamine, right? They all act on alpha beta receptors at varying concentration, varying degrees. So they act on the same part of the receptor, or the differences on the receptor also where they go and act, and downstream pathways. Because you add dobutamine to a person who's already on high dose norepinephrine, dobutamine also goes and acts on beta 1 receptor. So are there differences here, or is it, how is it?
Yeah, so noradrenaline is one of the drugs that has a little bit of beta 1 effect, but has a lot of alpha effect. So vasoconstriction is the first part, but there is a little bit, in some degree, some inotropic support. Dobutamine has the full inotropic support, so it's more powerful in terms of inotropic support compared to noradrenaline. I think in cardiogenic shock you need a little bit of both to support the patient if the patient is not doing well. But I'm not sure if you need to take dobutamine or another inotropic drug in that context.
So I think with that, we'll end the session. As there are no questions from the audience, we have a great audience. Thank you so much, Dr. Schaubroeck, for sparing your time, for teaching us, all our intensivists, and not only in India, across the globe. And soon we'll upload it on our YouTube channel. Thank you so much. And I thank the audience for their wonderful patience. Thank you so much, Dr. Schaubroeck.
Thank you for the invitation. It was an honor. Thanks.
Thank you.